Hello again. We're going to talk here about some complications of trauma to the abdomen, namely complications that surround the laparotomy. So the first one we'll talk about is abdominal compartment syndrome. This is relatively ancillary as far as the USMLE is concerned, but it's a good one to know, both for if you're on a trauma service, as well as to score those extra points on the USMLE. We'll also talk about the operative coagulopathies, 2 of them, and then some other post-operative complications that usually occur days to weeks after the event. So abdominal compartment syndrome is a complex and not fully understood pathophysiologic process. It's cyclical in nature, so it involves 2 major events. One, that you have a lot of fluids moving into the body, and those fluids are necessary because in a lot of cases with abdominal trauma patients, there's major blood loss, and so the patient requires fluids to keep their blood pressure up, to keep them alive. Number 2, there's also injured viscera, and that injured viscera is going to leak. So when you put the 2 together, you get the possibility of fluid in the abdomen, and that's going to increase the intra-abdominal pressure. So this cycle here illustrates that process. So you've got fluid resuscitation for critical illness, namely to keep the blood pressure up, and then total body fluid, third spacing, and edema. And then this elevates the intra-abdominal pressure because of the bowel edema. And then when the intra-abdominal pressure elevates high enough, you get compression of the vena cava. And that's going to reduce the return to the heart. And ultimately, what that's going to do is reduce the cardiac output. What also happens is that you get compression on the arteries supplying the kidneys. And that's problematic because that's going to lead to venous congestion in the kidneys, as well as decreased urinary output and azotemia. So there's various, and then of course you have to mention also with elevated abdominal pressure, that pressure can press on the lungs, and it can also, some of that pressure can transfer over to the pleura. And so that can cause decreased tidal volume and ultimately hypoxia and hypercarbia. So this is sort of a diagram of what happens. So as mentioned, this is an increased intra-abdominal pressure. The elevated pressure leads to vascular compromise, ischemia, and organ dysfunction. There are many different causes of abdominal compartment syndrome. Trauma is not the only one. Blood loss is not the only one. Pancreatitis can cause abdominal compartment syndrome. Burns can cause abdominal compartment syndrome. You can also get abdominal compartment syndrome from a ruptured aortic aneurysm, from a pelvic fracture. Really what is in common, though, with all of these is that there is injury and there is fluid resuscitation. And with the injury, you get injured tissue. With the fluid resuscitation, you get fluid, and together that is going to cause edema into the abdominal space. Abdominal compartment syndrome, when we're talking about it in the setting of abdominal trauma and trauma surgery, a lot of times it's discovered intraoperatively. So if the patient is unstable, they've had abdominal trauma, we send them in for exploratory laparotomy, we fix whatever needs to be fixed, we go to close the laparotomy, and lo and behold, we can't fit the skin over the abdominal contents. That is abdominal compartment syndrome. In this case, you don't discover it because of the symptoms, because the patient never had the increased girth and the pressure, etc. You discover it because you see that you've got edemic tissue. And that edemic tissue, because it's larger, can't fit in the abdominal cavity. And so in this case, what you're going to do is a delayed closure, and I'll talk talk about that when we talk about the treatment. If you discover this post-operatively, which is also possible, you may wind up being able to close the laparotomy, but then subsequently you get an increase in intra-abdominal pressure. Then in that case, the symptoms, the increased abdominal girth, the shortness of breath, syncope, hypotension, decreased urinary output, those will be noted usually within 2 days. So how do we diagnose this? Well, if it's intraoperatively, the diagnosis can be made on the spot. You can't close the abdomen. You can't close the laparotomy. If it's post-operatively, the best way to diagnose this is to measure the pressure in the urinary bladder. And the urinary bladder pressure tends to correlate with the intra-abdominal pressure. So if you have an elevated urinary bladder pressure along with these symptoms, then this is consistent with the diagnosis of abdominal compartment syndrome. You should also have metabolic panels and ABGs drawn at least. And that's just looking for the renal failure. You should see a pre-renal azotemia, and ABGs will give you a picture of acidosis. And you can compare this to your metabolic panels, and you should see that this is a metabolic acidosis. CT imaging will also show you the fluid in the abdominal cavity. So the treatment, when you have the patient in the trauma setting, when you're already doing the laparotomy and you note the fact that they have abdominal compartment syndrome because you can't fit the abdominal contents back into the abdomen and close the laparotomy, then what you're going to do is you're going to place a silo bag or a vacuum pack over the viscera and wait for the pressure to come down, and then you can close the laparotomy incision. If the patient, though, happened to be post-op and you discover it, then in that case you're going to have to release the incision, release the sutures, and then place the vacuum pack like that. So some other things that you can do medically, you can use diuretics to encourage the reduction of intra-abdominal pressure. Dobutamine can be useful to increase flow to the abdominal viscera. Remember, one of the things we're concerned about, like with any compartment syndrome, is reduced flow because of the pressure. And the abdominal viscera, what we're concerned about especially, is the small and large bowel. So dobutamine can be useful to increase flow there. Paracentesis can also be used to reduce fluid as well. But most of the time, you can leave these patients to the vacuum pack, and they should come down within several days. So here's a patient with a vacuum pack here. Obviously, you could see that there is no room at all to pull this skin over this belly. And these tubes are just pulling the intra-abdominal fluid out, and that's helping to reduce the pressure. Here's another one. So some complications you can get out of abdominal compartment syndrome include renal failure, which may require dialysis, respiratory failure, bowel ischemia, increased intracranial pressure, and reperfusion syndrome. And reperfusion syndrome is pretty difficult to avoid. So what we do for this is while the patient is receiving judicious fluids, we add mannitol and NaCO3 to the IV fluids, and this reduces the likelihood or reduces the severity of the reperfusion complications. Operative coagulopathy. So this is just a problem with bleeding during surgery that's not due to having an injury somewhere. So this is coagulopathic bleeding that happens intraoperatively. And there's two real big reasons behind operative coagulopathy: hypothermia and then dilutional coagulopathy. So hypothermia is the big one that you need to know about. And because hypothermia is an absolute indication for terminating the surgery. So hypothermia is just a reduced body temperature defined as below 97.7 Fahrenheit or 36.5 degrees Celsius. This is a definition of hypothermia. I am not exactly sure when a surgeon would want to terminate surgery if it's at 97.7 Fahrenheit or if it's lower. I wasn't able to find any consensus or any evidence-based publications on that, but the definition of hypothermia is 97.7 Fahrenheit, and what I have read is that hypothermia is an absolute indication for terminating surgery. So as far as we're concerned, then, if patient's body temperature drops below 97.7 Fahrenheit, that is going to mean that the patient needs to be taken out of surgery and they need to be warmed. Why is this? Why does hypothermia cause coagulopathy? The reason is that hemostasis, as you know, is an enzymatic process. There's lots of enzymes in that whole coagulation cascade. And as the body temperature decreases, that cascade slows down. And because that cascade is slowing down, you get slower clot formation, and that's going to lead to bleeding. Wherever you get injured, there's going to be bleeding longer than if the body were at normal temperature. So just because this is an enzymatic process, anytime you have an enzymatic process, if you cool it down, you're going to slow down the process. And that's exactly what happens. You slow down the clotting, and that leads to bleeding. And this increased bleeding is going to result in a decreased perfusion. Of course, if you're bleeding somewhere, then some tissue somewhere is not being perfused as it should. And that causes a lactic acidosis because you have ischemia of the tissue. Just like you have when you work out your muscles, you get a little bit of muscle ischemia because you're not getting enough oxygen, not enough perfusion, and your muscles secrete lactic acidosis. This happens in a much more significant way when you have bleeding resulting in the decreased perfusion here. This causes a severe lactic acidosis, which ultimately can cause a technical metabolic acidosis, a pH of less than 7.35. So this is what's another thing that you have to keep an eye out for. So if a patient develops hypothermia during surgery, the procedure should be promptly terminated and the patient should be warmed. You should also check them for acidosis, draw an ABG. If they have acidosis, that needs to be corrected. And the surgery may continue when their hypothermia is corrected and the acidosis is normalized. And some of the ways we get around this are to keep really nice, warm surgical units. That helps reduce hypothermia. Also, heating, those big heating balloons that they put over the patients, the bear hugs, that also helps protect from hypothermia. Dilutional coagulopathy is hemodilution due to significant fluid and packed red blood cell resuscitation. So when you are resuscitating the patient, what are you giving them? You're giving them usually crystalloids and red blood cells. Well, those red blood cells that you're giving the patient, they have very few to no active platelets. Most of the platelets that are in the packed red blood cells will die after 24 hours, and even the ones that are still active, alive, are damaged. So you're giving the patient red blood cells, but there's really no platelets in there. So what you have then is a hemodilution from the significant fluid and a iatrogenic thrombocytopenia from giving the fluid and the red blood cells. So basically all you have here is platelet bleeding because you don't have enough platelets. You also don't have enough of the plasma factors because that's generally not present in the packed red blood cells either. So what you do for this, if you have bleeding during surgery, assuming that they're not hypothermic, which you should always be monitoring, you can empirically manage the bleeding with fresh frozen plasma, which will replenish your factor, and platelet transfusion, which will replenish your platelets. So this is your first, dilutional coagulopathy is going to be your first inkling. If the patient has bleeding problems during surgery, especially if they have received several packed red blood cell units, like 10, 15, 20. And you'll just treat this empirically with fresh frozen plasma and platelet transfusion. So this is the trauma triad of death. I made this diagram myself. I'm really proud of it. I even downloaded this special font just for this. So these three things that you see in trauma, if they're present, it's very, very bad because this is a circular pattern of death. So metabolic acidosis. Where do you get metabolic acidosis from? Well, you get that from tissue ischemia, usually due to a lack of perfusion. Metabolic acidosis decreases the myocardial contractility, and that's going to decrease your cardiac output. So the lactic acid decreases the myocardial activity, and that's going to decrease your cardiac output. A decreased cardiac output cools the body down. And that's a problem because if you cool the body down, it's going to slow down the coagulation cascade. And now your coagulopathy is worse, and that's going to worsen tissue ischemia and the lactic acidosis, and so on and so on and so on. So it makes sense that if any of these start to become present, you need to fix it as soon as possible, because once one of these is present, then all three of these can start to happen, and it can spiral out of control in the trauma patient. Some other complications, an intra-abdominal abscess. This is exactly what it sounds. The symptoms include an abdominal pain, localized, fever, nausea, and vomiting. If you suspect an intra-abdominal abscess, a lot of times you'll be able to suspect it based on the fact that there will be a mass present, a tender mass. Get a CT. The CT will reveal the abscess, and then at that point you can decide whether you want to do percutaneous or surgical. That should be surgical incision and drainage of the abscess. Removal, I guess, is right too. I'm not a surgeon, so just get rid of the abscess, take it out, drain it. You should also start empiric antibiotics to cover gut flora. Hematoma rupture. So you can have a hematoma that develops during trauma and then is stable and then goes on to rupture later. So the symptoms would be after the patient is stabilized, moved on maybe to the ICU or on to a surgical unit. Now suddenly they have new peritoneal symptoms, rebound, guarding tenderness, etc. That wasn't there before. So for diagnosis here, depending on the stability of the patient, most of the time they'll be stable. You can get a CT. If they happen to not be stable, you'll just do that same fast exam that you would have done initially when the patient came in, looking in the left upper quadrant, right upper quadrant, in the pelvis. And the treatment is going to depend on the severity and location. You don't need to be worried about that for the USMLE, but it's going to involve some level of it's going to involve laparotomy, but you're going to need to find where the hematoma came from. And then the pancreatic pseudocyst, this I devoted an entire section to in the general surgery section, but this usually presents several days or weeks after the initial trauma. It doesn't even need to be significant trauma to the abdomen to cause this. And trauma is not the only thing that can cause pancreatic pseudocyst, but the symptoms would be abdominal pain, fullness, discomfort, early satiety. Occasionally you may be able to palpate the abdominal mass, and this can also cause biliary obstruction. And what can also cause biliary obstruction that's in the pancreas? Why, pancreatic cancer can do that. And you can get your Courvoisier-Terrier sign if you do a right upper quadrant ultrasound, where you have that enlarged, thin-walled gallbladder. So that's a possibility and a differential. For diagnosis, do an abdominal ultrasound. However, that needs to be followed up by a CT. And the treatment for pancreatic pseudocyst depends on the size. Usually it can be observed. Surgical excision will be done if it's greater than 6 centimeters.